Good day, everyone. My name is Kathy Kitely. I'm very pleased to be the host of today's webinar. I work as an oncology nurse myself in Ontario. I'm an advanced practice nurse in a clinical nurse specialist role. I'm also the director at large at the Canadian Association of Nurses in Oncology, which is a national organization, and I will be your webinar host for today. Welcome to the webinar. Our webinar today is entitled Oncology Nursing, Is This the Career for You? It will be presented by Jennifer Wernikowski. Jennifer is the president of CANO and has been since 2009. She is also an oncology nurse at the Dravinsky Cancer Center in Hamilton, Ontario. And I will do a little bit more of an introduction in just a moment. But before we get started, I'd like to briefly go over the format of this webinar. There will be two parts, a 45-minute presentation segment and a 15-minute question and answer session. All phone lines will be placed on mute during the presentation. At this moment, you may want to find your mute on your phone. You may post written questions during the webinar at any time using the chat box located to the right of the slides. After the presentation, the speaker will answer all written questions. And when there's no further written questions, I will take questions by the phone. Should you experience any technical difficulties, an operator can be reached by pressing star followed by 0 on your telephone. Well, at this point, it gives me tremendous pleasure to introduce today's speaker, Jennifer Wernikowski. Jennifer is a nurse practitioner in hematology at the Dravinsky Cancer Center in Hamilton, Ontario. Jennifer's clinical work focuses on hematological malignancies, autologous and allogeneic stem cell and bone marrow transplant. Her previous oncology nursing roles include Chief of Nursing Practice for the Dravinsky Cancer Program at the Hamilton Health Sciences and an advanced practice nurse for the breast disease site team at the same institution. Jennifer obtained her BSc at McMaster University in 1988. She followed that up with a Master's of Nursing degree from the University of Toronto in 2003. Along with her acute care nurse practitioner credentials, Jennifer holds a clinical cross-appointment in the School of Nursing at McMaster University, and she's also an associate member of the Department of Oncology of the Medicine Department at McMaster University. She's been an active CANO member since 1994, and she currently is the president of our organization. Her research interests have been in the area of breast cancer, cancer survivorship, advanced cancer nursing roles, and oncology nursing, as well as knowledge translation. And at this point, Jennifer, you may begin your presentation.
Thank you, Kathy. I want to thank everyone for joining us on the line today for our webinar. And as Kathy said, the title was supposed to be Oncology Nursing. Is it a career for you? And you will see that I have strategically left out the "is it" in the title that you see in front of you, because I'm hoping that when I'm done you'll be considering this very, very seriously as a possible career choice moving forward. I want to congratulate you all on the success you've already realized in your programs. And as you think about where you want to spend your nursing career, I hope you might add oncology to your list of considerations. As Kathy said, I have a long history in oncology nursing that goes back to 1988. And I hope that today you will get a little bit more of an idea what it's like to work within oncology, all of the various opportunities that are open to nurses. It's a very exciting field indeed. So let's move along. If you're having trouble technically with the slides, if you're not seeing what you're supposed to be seeing, just use that chat box at the side and you can let our coordinator know. The outline of the talk, and I'm going to be talking hopefully till about 1:45 my time, and we're going to talk about why cancer is an important healthcare issue. We're going to talk about the needs of Canadians facing cancer and the role of an oncology nurse, which can be very, very broad and very, very diverse. So I'm hoping to be able to paint that picture quite well for you today. How to get involved with cancer nursing, And we'll also review some frequently asked questions. This slide deck is something that's been out on the road and has been seen by a number of different schools of nursing across the country and in Ontario specifically. So we have collected up some of the most frequently asked questions, and we'll try to review those close to the end of the program. So cancer clearly is an important healthcare issue, and by this time as a student nurse, even if you've only got one clinical experience under your belt, you will most likely have interfaced with a patient who has cancer. Generally speaking, and these statistics come from 2008, and in that year 171,000 Canadians were diagnosed with cancer, and about 3,300 Canadians are diagnosed every week. That's pretty heavy on our hearts, I know. But also remember that the outcomes from cancer are getting better as well, and that leads to some new challenges in healthcare, very exciting ones. Cancer is the leading cause of premature death in Canada, and our new cases are definitely going up. And you can see there that by 2020 we expect that they're going to go up by 2/3. And there's a few reasons for that. Number one, as you all know, the population is aging. Our baby boomers are now getting older, and cancer is by and large a disease of older people. But also we're getting better at finding cancer. We're screening and finding cancers earlier, which also adds to the numbers. Some of those cancers, especially when they're found in much older people, may have gone completely undetected. If that older person would have passed away from other comorbid diseases, we wouldn't have even known they had it. And so there's a couple of reasons why that overwhelming number goes up. 50% of cancers can be prevented or detected early through screening and health promotion, and I'm sure you're starting to think about some of the nursing roles that might be involved in prevention or early detection. And here's another very new paradigm in cancer care. In the next 10 years, we're going to see a 40% increase in the number of people living with cancer or living with a history of cancer. And those survivors also have health care needs that can be managed very well by the system. The system is really now trying to figure out where do they fit. Do they continue to be followed in cancer centers and cancer clinics long-term after their disease is cured or no longer measurably there, or do they go back to their family doctors, or is there another model of care that might work better? And some of those new models of care involve nursing and nurse-led clinics, which is very exciting. So nurses do play a very critical role in providing very specialized care and services for individuals who are living with cancer through many different domains, including direct care, education, research, and also leadership. And there are tons of leadership opportunities within oncology nursing. So today we're going to try to talk about all of these domains, direct care, education, research, and leadership, so that you can understand how they work themselves into a job in oncology nursing. So this slide is really trying to show you in a very, very simple pictorial form what the cancer journey is all about. We know, and I know this from personal experience, that when I was a student nurse, I told my very best friend that I thought nursing would be just fine, but the one thing I really wasn't interested in learning anything about or trying to work in was cancer care, because it was too depressing, it was too sad, and I just felt that was going to be too draining on me. And then when I was in my late teens, my mom was diagnosed with ovarian cancer, and she quickly succumbed to ovarian cancer because at that time that was something that wasn't very well treated, and my sister was quite young. And it became probably my biggest fear. And eventually I realized once I became a nurse and I graduated from school, I could run away from that forever, or I could turn and face it and learn a little bit more about it and try to empower myself. I felt I had empathy and understanding for families that were going through that journey, and so I decided to give oncology nursing a try. You can see from this diagram, though, that those sad and depressing stories, although absolutely we have palliative care and end-of-life care at the far end of this diagram, there are roles for nursing all the way across, from prevention and screening for cancer, through the diagnosis of cancer, and during the treatment phase, both in outpatient ambulatory oncology clinics as well as inpatient oncology units and hematology units in hospital. And then there's this whole new domain, this whole new paradigm of recovery and survivorship, where the role of the nurse is paramount and important. And so you can see here that there's an awful lot of hope And there's an awful lot of positive things that can also happen across the cancer journey. And this for me has been the biggest learning, and I think it's why I've made this my career. Across the bottom of this, and you're going to see this diagram again and again through the presentation, is research and inquiry, because there are both formal opportunities to do original nursing research within oncology, but there are also opportunities to be the researcher helper bee if you really enjoy research, but you're feeling not quite ready to take that big step to do a master's or to go on and do a PhD. As a staff nurse, as a BSCN prepared nurse, as a newly graduated nurse from any nursing program, if you're interested in research, there are opportunities to work on projects, whether they're clinical trials, whether they're health services research, whether they're qualitative, which all nurses love qualitative research. There are opportunities to do that because most cancer centers and cancer hospitals are associated with universities and have active cancer research programs. So definitely keep that in mind if research is something you're interested in. We're going to walk through my presentation through the eyes of a case study, and we're going to talk specifically about Olivia, who's 48 years old. She's married. She has 2 young adult children in their late teens and early 20s. She has a very unremarkable past medical history, but her family history is positive. Her mother had breast cancer at the age of 45, and her dad had prostate and colon cancer when he got a little bit older. She had been through the breast screening program and had asked to be taught about self-breast examination. And so on doing self-breast examination, one day she noticed a lump in her left breast. She went on and had a mammogram and an ultrasound and a biopsy done by a needle. And then she had to go on because there were cancerous cells in that biopsy. She had a formal surgery called a lumpectomy and also had some of the lymph nodes taken out from underneath her arm. It turned out that the tumor was kind of medium-sized, a garden variety, something between 1 and 2 centimeters. And she had a few lymph nodes involved under her arm, but not more than 5. And there was no distant disease. That M0 means everything was confined to the breast and the axillary lymph nodes, and there was nothing anywhere else. It was growing medium fast, grade 2, and it was sensitive to hormone therapies. Receptor positive means hormone therapies are going to work on her breast cancer. And it wasn't particularly aggressive. It didn't have a HER2 expression, which is a good thing. She was treated with chemotherapy, and she had radiation therapy also after her surgery. So we've learned a lot about her here. We've learned a little bit about her social life. We've learned a little bit about her disease and how she came to be diagnosed. And imagine that she probably has a little bit of background emotional baggage associated with breast cancer since her mother also had it. So start thinking about what the role of the nurse will be for Olivia across that trajectory of care. So the likely course of her cancer journey is probably going to mean that she's going to come to the ambulatory cancer clinic. She's going to be taught about the various therapies, chemotherapy, radiation therapy. It's most likely that her chemotherapy will take about 6 months to get through, and she'll likely have an additional 3 to 6 weeks of radiation therapy after that. She's going to have lots of needs. They're going to be physical needs around symptom control, and she's going to have emotional needs around her fears of cancer recurrence and facing serious illness, managing her social relationships and her family. She'll have some spiritual needs. She'll have some practical needs perhaps because she'll be not working. So she's going to have a number of needs in a number of different domains. And so what role can an oncology nurse play in meeting some of those? So let's just talk through what this is going to be like for her. Firstly, in prevention and screening, a very important part of the cancer journey, which we often don't even talk about because really we don't know it's cancer until it gets diagnosed in the second box. But prevention and screening is incredibly important. Many cancers can be easily screened for in order to promote early detection. The earlier you detect a cancer, the easier it's going to be to treat and to hopefully cure, especially in the cases of breast cancer, cervical cancer, colorectal cancer, and testicular cancer. So screening is incredibly important. But even before screening, prevention is also incredibly important. Some examples of prevention are screening colonoscopies, for example, because when you do a colonoscopy, and if you're able to remove a polyp during a colonoscopy, you've actually prevented a cancer from growing. Some of the other ways we can prevent cancers, especially those that we know we can detect by genetic risk, like breast cancer, BRCA1 and 2 genes, for example, you can use certain medications to prevent cancer, breast cancer, from growing if you have one of those genetic mutations. So as a nurse, you may work with a genetic counselor, or you may do some extra training as a genetic counselor to help patients understand their risk of developing cancer later. Or you may work in a screening program such as breast screening or colorectal screening. At my hospital, the flexible sigmoidoscopy colon screening clinic is completely run by nurses. Nurses do all the screening, including the scoping. And that's not an advanced practice role. So incredibly diverse new roles are coming up all the time. So we've talked a little bit about those nurses, but what about other nurses in screening, like a public health nurse, for example, a community nurse, and as I said, the flexible sigmoidoscopy nurse. So next for Olivia, she's been to breast screening. We don't always teach self-breast exam and breast screening. It hasn't been taught to change, or it hasn't been found to change outcomes for breast cancer patients, but she asked for it specifically and got it at the breast screening clinic. Now she knows she has a lump, and she's going to be going through some diagnostic tests to try to understand, number one, is it really cancer? And number two, if it is, what stage of cancer is it? Because the stage of cancer will certainly help to determine what kinds of treatments are going to be an option for her. So she went on to have a mammogram, a very difficult test for women. I still have to sign up for my first one, I'm embarrassed to say, and I know all about them. So therein lies the challenge of getting people to participate in screening. Mammograms, as you know, basically is a diagnostic imaging test which takes the breast and flattens it between two plates and can detect abnormalities in the texture of the breast tissue. And if certain abnormalities look classically like breast cancer, and if they do, then the patient will go on and have a biopsy of that area. And in breast cancer, we can do that with a needle. And here you can see just in cartoon form the needle going into the tumor and trying to pull out some of the cells. And if they show up to be cancer, then you know that it's a cancer. Some of the complications that can happen around this time are misinformation. And so nurses that work in diagnostic areas such as breast screening or within diagnostic imaging areas in hospitals have a very big role to play with patients around information, how the tests are going to be interpreted, what they mean if they're positive versus what they mean if they're negative. And a great example of that would be this particular biopsy slide. If you put a needle in and you pull out some cells and they look like cancer, then you know you have cancer. If you put the needle in and you pull it out and there's no cancer cells, negative isn't really negative, especially if that lump feels firm and it feels very suspicious for cancer, and on mammogram it still looks like it might be cancer, then there may still be more tests. So a nurse might have a role to play in a patient who says, oh, I hope this needle biopsy is negative, where the nurse might be having some knowledge about cancer to say, well, you know what, we may not yet be finished if it's negative. There might still be more tests that we need to do to make sure, you know, that this is clear and that we don't have to go on for any further treatment. So there certainly are roles for nurses in that area. So cancer can be detected or diagnosed by a number of different methods. One is physical examination, absolutely. There are two kinds of oncology nursing, so to speak, two great big buckets. One would be oncology, those cancers that make big, solid, lumpy tumors that can sometimes be easily detected on physical examination. And then there are others, more hematological within the blood, that are a little bit less defined on physical examination, where you absolutely need other things like lab values to help you diagnose them. Lots of cancers come with lab values attached to them, and oncology nurses know that full panel pretty well. Surgical interventions are very important, especially for solid cancers. It's the number one treatment for solid cancers. If you can remove the bulk of the cancer through surgery, then the remainder of the treatments sort of become a little bit less complicated. But a surgical intervention is sometimes required for diagnosis, because a good example is Hodgkin's disease. If you don't have a surgical intervention to remove the entire lymph node, then you're not going to be able to get an accurate diagnosis. And radiological interventions are used increasingly in diagnosing cancer through CT-guided biopsies, MRI-guided biopsies, and interventional radiologists are becoming very increasingly important in this area, as well as nurses that work in diagnostic imaging suites. So some of the roles for nurses would include the nurse geneticist, would be important in the diagnosis of certain cancers, especially for patients who are at increased risk because of their family history. Sometimes if patients carry with them a gene that increases their risk, their treatments may actually be different. So getting those genetic tests done even after diagnosis can be important. Radiology nurses, surgical nurses on surgical inpatient units or in surgical clinics, and also rapid diagnostic clinics. such as breast screening. Some breast screening clinics are now rapid diagnostic clinics where women can come, get their screening mammogram. If it looks suspicious, they'll be brought back right back in the same day for a biopsy, and a pathologist is available right there to read the pathology that day, and everything happens all at one time, which is a bit mind-blowing to me, and you can imagine the nursing roles there. So next for Olivia is treatment, the treatment part of the journey. This is the part probably that causes the most anxiety for patients. There are different treatments. We talked a little bit already about surgery and how that can be used as a very major treatment for cancer, removing the entire tumor that we can in surgery. But also radiation therapy, as you can see at the left there, using high energy X-rays to treat cancer, to kill cancer cells and spare healthy non-cancerous cells. And then in the bottom right corner, you can see a woman who's preparing to receive chemotherapy injection. These are cytotoxic medications that are injected that work on quickly dividing cancerous cells in order to be able to reduce the burden of cancer or eliminate cancer altogether in the body. Chemotherapy has changed in huge ways over the last number of years, and so some of the medications that are being given in chemotherapy suites are no longer the classic cytotoxic medications that I remember when I first graduated. Incredibly, now we have more and more therapies that are very targeted. We use a lot of monoclonal antibody therapy. Those monoclonal antibodies are designed in a lab to specifically target very particular cancer cells so that when they're injected into the patient, they drift and migrate around the body and they attack specifically the cancer cell and only the cancer cell and spare a lot of the side effects. And actually the outcomes for patients receiving monoclonal antibody therapy or tyrosine kinase inhibitor therapy are amazingly just going up all the time. You can start to see in all of these various therapies the kind of specialized knowledge and skills that oncology nurses need to gather up. So cancer nursing isn't all about palliative care. It definitely has terrific opportunities to dig into clinical trials, to understand better the activity of very toxic medications and to manage those side effects, to be able to teach patients about side effects of therapy and to be able to quickly assess a patient and see when early signs of toxicities are rearing up their heads so that you can advocate for changes with the team in order to make sure that the patient can be as well as possible through a very tough time. Side effects of radiation also can be quite uncomfortable, and it all depends where the radiation is being given. So wherever that radiation is being aimed is most likely where the patient is going to have the most side effects. In someone with breast cancer, like our patient, she may have breast swelling, she may have breast pain, she may have reddening of the skin, she might have itchiness of the skin. She could have a little bit of nausea. It would be unusual. Certainly she would have some fatigue. But if we were treating someone through their abdomen, then obviously they would have problems with diarrhea. They might have nausea problems. They would also have perhaps some skin reaction. So you have a lot of things that you would have to be able to tease apart as the nurse. What kind of assessment am I going to do today? Where is that radiation being aimed? What kinds of side effects am I thinking the patient's going to be at risk for? And how am I going to teach them about looking after themselves as best they can to minimize those? So it's certainly very fascinating. So these are the three ways: surgery, chemotherapy, biotherapy, which we talked about, and radiation therapy. Look at all the roles for nurses in the treatment phase. Working in the chemotherapy suite, working in an apheresis clinic, that's sort of helping patients get ready for bone marrow transplant, for example. Bone marrow transplant nurses who work on inpatient settings. Surgical nurses who work in the operating room or the post-anesthetic care unit or in the medical surgical unit. All of these nurses are interacting with cancer patients. Nurse navigators, an increasingly interesting role of a nurse navigator. Cancer therapy and cancer diagnosis are, for the most part, all happening outside of the inpatient setting. So most patients have some symptoms, go off to the family doctor, who then sends them off to the surgeon, who sets them up for a biopsy, perhaps some surgery, and then after that you have to meet with maybe a medical oncologist and think about chemotherapy, maybe a radiation oncologist. Chemo and radiation often given as outpatients. So we start to count up all the interactions with the system a cancer patient might have throughout their journey with cancer. By the time they get to finishing their treatment, they may have interacted with over 300 people. So a nurse navigator becomes important to try to be, almost like a primary nurse or a primary navigator for that patient and family to ensure that they have a good understanding of where they go, why they go, and what they can expect when they go to some of these different appointments. Oncology units, inpatient oncology units and hematology units, obviously a great place for nurses to learn the ABCs and all the building blocks of oncology and hematology, including diagnosis, including the treatments. This is the area where a nurse would be able to participate in chemotherapy certification courses and all those kinds of things. Community health nurses obviously too play a big role. So lucky for Olivia, she got through her treatments with very minimal complications. She had a few toxicities from chemotherapy, one admission to the hospital when her white cell count became low and she developed a fever. But apart from that, she did very, very well, and was told at the end of her treatments, we're going to just be following you now. Every 3 months you'll be back to the cancer center for about the next year, and then we're going to see you every 6 months, and then after that you'll be discharged back to your family doctor, and you'll go on with surveillance and mammograms and yearly checkups from there. So you can see how she's going to link right back now to prevention and screening. We don't want to forget about the fact that someone who's had chemotherapy in the past is going to be at higher risk for developing other cancers in the future because chemotherapy can put you at risk for that. And also she's at higher risk than the general population for developing another breast cancer, a brand new one. So she'll have to participate in prevention and screening through her family doctor. So this is great. It loops back around to prevention and screening, and you can see that she's had an excellent outcome. 2/3 of women diagnosed with breast cancer, maybe even more than that now, are actually going to find themselves on this part of the journey. And the role for the nurse in recovery and survivorship is increasingly growing. So patients who have survived cancer therapies, gotten all the way through, their cancer hasn't come back, they tell us lots of things. They have very high emotional needs. They have very high fears with respect to risk of recurrence. They have a hard time separating themselves from their oncology team because that team's looked after them for the last 18 months, and now they're basically saying, okay, we don't need to see you for 3 months, or perhaps they're even being discharged back to their family doctor. So this is where we start to learn a little bit about what their information needs are and how we can best look after them to keep them feeling confident and happy about the great outcome that they've had. So some of the things that are starting to happen with respect to survivorship in cancer clinics are ideas around what's the best follow-up model of care for patients who are survivors of cancer. Maybe we need to transition patients from their active cancer clinic appointments. And at an active cancer clinic appointment, a nurse will always be there working with the physician, or hopefully always, for patients who have needs of a nurse. Sometimes the nurse has a very much a leadership role where they'll actually see the patient, examine the patient, talk to the patient about what's going to happen next, and the physician's role may be smaller. Other patients who are having more physical symptoms, more physical needs, may see more of the physician and a little less of the nurse. So it all depends on what the patient's needs are. But certainly patients are going to need psychosocial counseling. They certainly need to have screening and follow-up set up for them, and some pretty intense health teaching around making sure that we can maximize that good health. So thinking about prevention and screening, thinking about talking to them about exercise and healthy diet, all of those prevention activities, which nurses are very good at doing. So nurses' role in the survivorship phase include educators, absolutely. We do put on talks for patients too when they're finished their therapies, try to bring them together in groups and put on more formal opportunities for them, as well as doing some of that teaching in the clinics. A genetic counselor, this is the third time a genetic counselor has come up in the talk. A nurse navigator again, advanced practice nurses, nurse practitioners, clinical nurse specialists play a big role here, as well as psychosocial APNs. We have a mental health APN working at my cancer center who specifically works with patients who are having problems with depression and anxiety secondary to or in addition to cancer, and also the family doctor office. Nurses working in family doctors' offices can have an awfully big role to play in survivorship. If it doesn't go that well, if the cancer were to come back, cancer can come back in a number of different ways. And this is something that nurses, especially nurses who work in clinics, may face on a fairly regular basis. So the cancer in the breast is gone, the cancer's been removed by lumpectomy, patient's gone through all this therapy and comes back for a routine visit, and the nurse does the examination and sees a little bit of new puckering in the skin around the old surgical site, and on breast examination feels a craggy, kind of stuck down, hard little tumor in the bed of the original surgery, and she knows, oh dear, this doesn't feel normal. It's an opportunity then to talk to the patient about what's happening, what I think is happening. Nurses do not diagnose, obviously, so you always have to be honest, but also say, I'm going to have the doctor come in and feel this because it's not the same as it was the last time you were here. And then the doctor may come in and recurrence might be found. There's lots of ways to deal with recurrence, and different cancers recur in different ways, and recurrence has different meaning for different cancers. So some cancers can recur and yet still be easily treated. The patient can still find their way to recovery and survivorship. They may need a little more treatment. It might mean more surgery. It might mean more chemotherapy. It could mean radiation therapy if radiation therapy hadn't been used before. And then they find themselves back in recovery and survivorship. But recurrence is a time of high anxiety and big emotional psychosocial needs for patients. The role for the nurse is enormous. For some patients who have recurrence, this may move us into a non-curative picture, where cancer becomes a chronic disease. Cancer becomes something that isn't making me sick today and may not make me sick tomorrow or next month or maybe even next year, but we know it's here. It's grumbling along. This can look very different for all the different cancers, and certainly we know now that there are a huge number of patients living in our communities, many of them going to work, leading full lives, but knowing that they have active cancer. And they may be taking some oral chemotherapy. They may be coming for some intravenous chemotherapy, or they may be on a watch and wait plan. And think about that and the role of the nurse depending on what that plan is actually like. Helping a patient live with watch and wait, helping a patient live through ongoing year after year chemotherapy, much like a diabetic would be doing on insulin. And then eventually, when we know that cancer is still there, still grumbling in there chronically, that patient is eventually going to find their way to palliative and end-of-life care, where, of course, the role of the nurse is enormous. That trajectory across from recurrence over to palliative and end-of-life care can be anything from a couple of weeks or even less for some very aggressive cancers when they recur to many, many, many years. And in some cases, in my own practice, I can tell you that some of my patients lived for decades in that trajectory. So lots of opportunity there for building relationships and helping them with all the psychosocial domains of care as well as the physical domains of care. So this really is one of the areas that I find to be incredibly rewarding, and I know that many of my nursing colleagues share that as well. But palliative care is special. End-of-life care is certainly special. This is an area where nurses have for a very, very long time had leadership roles in the community and in hospitals. This can include things like comfort measures, pain and symptom management. Also includes working with the family. Symptom management from chemotherapy, from surgery and radiation, in addition to things that are being caused by the cancer itself, which can be pain, nausea, constipation, those kinds of things. Psychosocial counseling and care, which also includes ensuring that we have all the right referral sources for the patient. So the nurse may actually act as the pivotal point for the care plan, be the one to assess when we need to bring in palliative care physicians, for example, when we need to bring in social work, when we need to bring in more home care services, when we need to bring the patient back to hospital. Nurses' roles in palliative and end-of-life care can include those nurses working in community, those nurses working in hospitals, specialty palliative care units, or even tertiary palliative care units, which are units in hospital designed specifically for patients at the end of life, but not for patients to come and actually die in hospital, for patients who want to die at home but need to come in because pain and symptom are getting out of control. And they need an interdisciplinary, comprehensive assessment in order to come up with a different plan to manage their symptoms. The goal is to have patients in and out within about 3 days and then back home feeling much more comfortable. Hospice nurses, an excellent opportunity for nurses, and of course hospice is specifically geared to end of life, not only cancer patients, but for a wide variety of patients. Psychosocial grief counselors, but also let's not forget chemotherapy nurses, nurses who work in surgical settings, those nurses who work in radiation therapy treatment centers, because those modalities of care can all be used for symptom management even at the end of life, which I think is something that is a surprise to many nurses. Some chemotherapies can be used to great effect to relieve obstruction, to relieve pain, and the same is true for radiation, which can be used to treat pain, obstruction, also bleeding. So these patients at the end of life can find themselves in radiation treatment bunkers, for example, and it takes a very special and knowledgeable nurse to be able to provide them with the information, the assessment, and the care that they need at that point in time. We have a comprehensive supportive care framework that we use in oncology nursing, especially in Canada. This was penned by Dr. Margaret Fitch from Sunnybrook, and some of you, if you're very lucky, you will have interfaced with her during your studies, or maybe you will going forward in your careers. She's very thoughtful, and she's very broadly published in the areas of supportive care and cancer. And this particular framework I love because it puts the patient and the family right in the middle, the individual living with cancer. And it highlights for us all the various domains, all the areas where we need to have knowledge, skill, very specialized oncology-related knowledge and skill to be able to care for patients with cancer. In the psychological domains, with respect to some of those psychological reactions to not only a cancer diagnosis, but also to long-term treatment and feeling crummy, or to issues related to survivorship, and my life is just not the same. I am in a whole new time of my life, but all my family and friends want me to get back to normal. But I'm a new normal, and I need them to get to know me. Those kinds of struggles are very, very common in survivorship. Social issues, relationships, the way that people relate not only to their spouses, but to their friends, to their work community. Whether or not they even want to go back to work might be included in social. They may decide that they've got other plans. Spiritual care, informational care, of course, ongoing information is important, and patients never, ever tire of getting information. We can see from most of the survivorship literature that patients will continue to say that information needs are one of their highest needs, and often they come to clinic with lots of information to get through. What about this new treatment? What about that new treatment? Should I have had this treatment instead of that treatment? We know that clinical trials are being published all the time, and patients who are on follow-up might find out that we've just published a clinical trial that shows that the treatment that they received maybe isn't quite as good as this new treatment. A nurse needs to be able to respond to that, to be able to reframe that information for the patient so that they don't sort of live the next couple of weeks thinking, well, I got the second best treatment now. I'm probably not going to do as well. These things happen all the time, and it's very important for the nurse to be able to react and respond. Practical needs, emotional needs, physical needs are of course, ongoing. Survivors from cancer will have ongoing health care needs related to late cardiac toxicities from their treatments, other late effects of treatments, pain, and other things which will have to be continually assessed, and care plans will have to be monitored and changed as needed, so it doesn't stop. Ways to explore if oncology nursing really is for you. Well, I think the first thing that you've done today is you've come to listen to me talk a little bit about oncology nursing and why I love it. Kano is certainly there for students who have questions, and we'll talk about that also a little bit later. But you can talk to an oncology nurse about their experiences, the challenges, the rewards, and opportunities of cancer nursing. You can hopefully identify a faculty member at school who might have a background in oncology, or could hook you up with someone who does, so that you could talk about the opportunities at your school and perhaps beyond your school for placements in oncology. Some schools now are offering oncology-specific undergraduate and graduate curricula, which is very exciting. You can look for opportunities in oncology nursing in your clinical placements or in externships if you have an opportunity to participate in those. Think about doing one of your school papers or assignments on an interesting aspect of cancer care. You will never, ever, ever come up empty. There will be literature there to help you. I can almost guarantee it, no matter what your question is. And then check out our website for more information for students. So a day in the life of an oncology nurse, I hope I've started to be able to paint a bit of a picture for you. The big message I want you to take home today is the fact that cancer nursing can be anything from prevention and screening to diagnosis and treatment, to recovery, survivorship, or to recurrence and palliative care. There are opportunities in inpatient units. There are opportunities in outpatient cancer centers. And even in the cancer center, there are opportunities within the chemo suite to be giving chemotherapy and interfacing with patients getting active treatment. You could be working in the clinics, seeing brand new patients, newly diagnosed with cancer, patients who are receiving active therapy, just getting followed up and watching their symptom management, or you could be seeing patients in follow-up in those clinics, working in the radiation clinics as well. And I think one of my most fun jobs was working in a radiation therapy department where I had my own assessment office, and I came to work from 9 till 5, and any patient that was getting radiation therapy that day, the radiation therapist could bring them by my office if they were having problems with pain or symptom management related to the radiation therapy. And so basically it was like a walk-in clinic for radiation therapy. It was run entirely by nurses, gave us an awesome opportunity for providing leadership and to do health teaching and to do assessments and to interface with the team and let them know what we thought. One thing about oncology nursing that has always made me incredibly proud and happy is the way nurses are treated within the extended interdisciplinary healthcare team. I've always felt that the voice of nursing is heard and very much valued, and it makes me very proud. And even to this day, I'm working back on an inpatient unit with nurses in bone marrow transplant, and their abilities and the way that they can communicate about their assessments and the way they advocate for patients and families makes me incredibly proud. So there are endless opportunities for cancer nurses. It's not always happy, and it can get sad. Some nurses have really terrific opportunities and very, very good skills in palliative care, and certainly if that's something that's interesting to you and you know that already as a student, I would encourage you to think about cancer nursing. And I'm happy to answer any questions that you might have about the day in the life of an oncology nurse. The other thing I would highlight for you is my opportunities to participate in leadership activities as a cancer nurse. I was able to work as the Chief of Nursing Practice here in the cancer program for over 4 years, which is a terrific opportunity to be able to learn a little bit more about research, or to learn a little bit more about leadership and leadership skills and how I might be able to support other nurses in their work through a leadership opportunity. So CANO itself is the Canadian Association for Nurses in Oncology. We're a national organization with about 1,000 members. We support nurses to promote and develop excellence in oncology nursing practice and education, as well as research and leadership. And on the web, you will see some of the resources that we have available to all of our members, including learning resources like an e-learning resource related to cancer-induced nausea and vomiting is one example, but also a whole new resource for nurses who find themselves interacting with patients who are in the survivorship phase of their cancer, because that also is a big challenge for us. So I hope that you'll remember CANO as you go forward, and if you have any questions or concerns, or if you've got any further topics you want to explore with us about cancer nursing, we'd be very happy to respond to those. Some of the benefits of joining CANO include our quarterly journal that comes out both in English and French and will now be coming out online as of our very next issue. We have a number of different practice standards and guidelines to help ensure the highest possible quality of nursing care. One of our greatest hopes is that Canadians across the country, no matter where they live, whether they're rural or whether they live in cities, will be able to interface with nurses who have the knowledge and skill that they require to safely look after them. We have a great website. We have an e-newsletter that can come straight to your email box if you're interested, with super links to more information, big chapter events in all the provinces, as well as our annual conference. We have special interest groups as well, including palliative care, radiation oncology, and surgical nursing, just to name a few. And students' costs are discounted, both for membership and also for attending our annual conference. So there are some frequently asked questions that we tend to get from some of our students when we give this presentation. One of them is there a specialty training for oncology nursing? We do have a CNA through the Canadian Nurses Association. Oncology is one of the certification categories. There are some requirements to be able to write that exam, and one is just around, I think, 2 years full-time hours in an oncology setting before you would be qualified to write. But many of our oncology nurses across the country have been writing this exam. It's been available since 1997. Are there research possibilities? Absolutely. We talked a little bit about those, both in clinical trials nursing and in primary research opportunities in labs. We have in the area where I work, we have a number of clinical trials nurses in the Cancer Center who work in all the site groups together with the primary investigators in order to be able to make clinical trials available to patients. We know from randomized studies that patients who are randomized onto any study are likely to have better outcomes than patients that don't participate in clinical trials. So it's very important. And also primary research opportunities to do original nursing research or to work with nurse researchers on some of their projects. Challenges and rewards. I'm such a fan of oncology nursing, so of course I have to highlight these for you. Tons of options. I've worked in pediatric inpatient. I've worked in breast cancer outpatient. I've worked in chemotherapy suites and radiation suites. I've been a leader. I'm back to inpatient nursing. I never get bored. There's absolutely always something to keep me engaged and excited about oncology nursing. Lots of opportunities, growth, personal and professional. I think one of the greatest skills that I have been able to hone in oncology nursing is my communication skills and my psychosocial assessment skills. I'm very proud of those. Making a difference and being a leader in healthcare, having a voice, both in the Canadian Partnership Against Cancer, which is a national organization looking to sort of revamp the way we provide cancer care. CANO has a voice at that table. Accreditation Canada, who provides accreditation to all the hospitals across the country, just sent CANO a nice list of possible standards that might be added around the provision of chemotherapy. So we do have a voice and we do make a difference. We are trying to be leaders. Need for self-care, you have to look after yourself in any area of nursing, and that goes without saying. Need for support and also reflection. So I hope that I have convinced you all that oncology nursing is something to consider, and I hope that you will also check out our website if you have more questions about it. And at this point, I think I'm going to pass it over to Kathy Kitely. I'm a little bit late by about 4 minutes, and Kathy's going to run the question period for us. Thanks, Kathy.
Thank you very much, Jennifer, for a most informative presentation. And we will now be moving to the question period. So if anybody has a question that they would like to submit or have already submitted through our chat box, we will answer those questions, followed by the ability to ask questions on the telephone. So it looks like we do have a question, and I'll read it and pose it to Jennifer. When working with an oncology nurse, she noted that patients that received chemotherapy during the night did better than those that did it during the day. Are there any studies that explore the relationship between the time chemotherapy is given and prognosis?
Well, that's an excellent question. Not that I know of, and I think it really does depend on what the nurse means by did better. There are some patients in my own experience who like to get chemotherapy at night because then they're not staring at the infusion watching the drops go in. So if they can get their chemotherapy overnight while they're sleeping, they seem to tolerate it better because they're not dwelling on it. So when they wake up in the morning, it's all done. I can tick that off my list. And some patients will say that they feel better. But I'm not aware of any studies that actually say that chemotherapy given at night changes outcomes. And I think if there were studies that suggested that that were true, cancer centers might be open all night and closed all day, or we might be ordering chemotherapy on the inpatient units such that most of the infusions would happen at night, and currently that's not what's happening. So Kathy, I don't know if you have any more information about that. I'm not aware of that.
No, I'm not aware of any studies either, other than sometimes from a safety perspective, the house is just a little bit more populated during the day, and we tend to give chemotherapy during the day. Lights are on, people are around, and there are plenty of resources both near and far. So we too, I think that would be common across the nation that most chemotherapy is provided during the day. Not aware of any studies, other than the notion that during the evening and night, when lights go down, patients can get a little bit more frightened and worried, and there are other studies that link to people's moods sometimes dipping a little bit as the light goes down. And a question from Christine. Does CANO highlight differences in oncology nursing responsibilities across the provinces?
This is an excellent question. Love this question. And I think that the answer would be it's not really CANO's job to highlight the differences. What we try to do is articulate the standards that we believe all nurses interfacing with cancer patients should be able to meet a certain standard, and that there are also performance criteria that goes along with those standards, the competencies, if you will. And that although nurses may find themselves in different situations in different provinces depending on how healthcare is organized, certain standards and competencies really do need to be met. So we outline those in our documents, and then we make those available not only to practicing nurses but also to healthcare leaders so that they have an understanding of, what is it that we need to make sure we have in the work environment for our nurses to ensure that the patients who are being cared for here are going to have the best possible and the safest possible care. We do know that there are differences across the provinces, and because healthcare is provincially managed, that's really not something that we can always avoid.
Thank you. Still another question from Katerina. You mentioned certification after working on an oncology unit for 2 years. Is there any training required to be hired on an oncology unit? Also, is there specialty training required to work in a treatment clinic?
Great questions. New graduates can certainly find their way to roles, especially on inpatient cancer wards. Managers, of course, are very aware that newly graduated nurses are not going to have specialty training in oncology, or at least not usually, apart from a couple of different schools in the country that may have some oncology-specific courses in the curriculum. Most students who graduate aren't going to have that. So it is the responsibility of the hiring manager and the unit educator to make sure that new graduates who are hired on get the required training in order to be able to safely provide chemotherapy, for example. We do have in Ontario chemotherapy administration courses that are now administered for the most part through the D'Souza Institute, and I know some of the D'Souza people are on the line with us. They have an excellent chemotherapy program for newly hired nurses in oncology settings. Some hospitals and some organizations across the country still have their own in-house programs, so once you're hired onto the oncology unit, and if that's a place where chemotherapy is given, certainly that type of course or that kind of training will be made available to you. If you have an opportunity to have an oncology placement as a student, certainly that counts towards your experience when you're looking for a job.
We'll take one or two more questions on the chat line and then open it up to questions on the line. This is an excellent question as well from Lori. Hello. Are there any in-services or conferences that we as students can add to our portfolio?
Oh, that's a terrific question. We try to make sure that all of the webcasts and webinars that are done by Cano are available as an archive, and if you're having trouble accessing those, our members all have access to those, so certainly you can look into those. And I'm not sure about other in-services. Well, conferences, obviously there's lots of conferences. Cano has an annual conference every year. This year it's going to be held in September in Halifax. There is a reduced rate for students who want to attend, but also if students are members of Cano, you'll also find on the website archived presentations from past conferences that you can still access. The slides and some of the information about those are available on the website.
Great answer. Sometimes you just have to really sneak around and find out what's going on, and things are not always advertised really broadly within your organizations, but putting the feelers out are very helpful. Our last question on the
Kathy,
chat
there's
line.
one other thing we should probably say about that, and that is the importance of the nurse educator on the units in the hospitals where you tend to have your placements. Nurse educators in oncology would be great people to link up with if you're looking for in-services or things that are going on locally that you might want to tap into.
Excellent thought, Jen. Our last question on the chat line today will be, as a new grad, do you recommend any particular courses for students? I've lost one second. Let me just make sure I read this right. Do you recommend any particular courses or other suggestions for education while applying for job opportunities in a cancer clinic?
Kathy, can you just tell me that one more time?
Yes.
Kind of long.
I certainly can. As a new grad, do you recommend any particular courses or other suggestions for education while applying for a job opportunity in a cancer clinic?
Yeah, great. That's a great question. So I would just mention it for anybody who's thinking about this within Ontario. We do have the D'Souza Institute, which is housed at Princess Margaret Hospital, but a government-funded institute that can help with education and training for nurses who are either working in oncology settings or want to work in oncology settings. Just Google D'Souza, which is small d, small e, capital S-O-U-Z-A. Just Google D'Souza Institute, and you can hook up with D'Souza and see what they have to offer. For nurses who are outside of Ontario and you're looking to get a job within oncology and you're trying to make sure that your resume looks as beefed up as it possibly can, it looks very self-serving for me to say, join your national professional organization. But of course, membership in professional organizations shows a manager that, this is something I'm very serious about. I've invested a little bit of my own money. I've become active in this organization. Perhaps you join a special interest group or become an active member of your local chapter. This is definitely going to have meaning to your manager. Make sure that if you are a member of CANO that you let them know that. CANO has also got a number of different educational resources on the web which you can complete or read, or you can make sure that the manager is aware that you've done those. Some of the local schools will have, universities will have certain oncology courses that you might be able to take. And as I said, also hook up with the nurse educator at the organization where you're hoping to get a job and see if there's anything local that might be available. For example, in Hamilton, for a very long time, there was a certificate course that was available through the local college around oncology and oncology nursing, which new graduates would sometimes enroll in and get a few courses under their belt, and that would really help with their resume as well if they had nothing in particular from the university. I don't know that that's still available since the entry to practice for nurses has become all BSCN. That might have changed. But your local nurse educators will definitely know that. So if you can't get that information from some of your faculty advisors, you might be able to get that from nurse educators.
We are 1 minute away, so I think what we will do is ask the last question on the chat line, and then unfortunately we'll need to say goodbye, but this has been most stimulating in terms of questions. Our last question of the day is from Lisa, and Lisa's question is, do radiation or chemotherapy treatments jeopardize the health of nurses?
Oh, that's a fantastic question. There are lots and lots and lots of policies and procedures and safety with respect to safety, both in radiation therapy and in the administration of chemotherapy. Within the radiation areas, really, that's not so much of a concern because nurses who work within radiation treatment areas either have offices away from those main bunkers. So the radiation therapists who give radiation certainly have a little bit more to think about when it comes to radiation safety than nurses that might be working in that area, because all of that has to meet very strict standards with respect to radiation therapy in order to ensure safety for people. When it comes to chemotherapy, though, that's where it really becomes up to the individual who's giving chemotherapy. There are policies and procedures about personal protective equipment that are all based in very strong evidence, and we have very strong recommendations both from the Oncology Nursing Society as well as through NIOSH and other organizations around what has to be in place to safely give chemotherapy. That includes eye protection, respirator masks, and gowns, and special gloves. And what I often see is that nurses take that all very, very seriously. And sometimes when other people, learners, residents, physicians go into a room to pop a little chemotherapy into an LP or whatever, they may not be as up to date on what personal protective equipment they need to wear. And it becomes something that nursing is a real leader in. I don't want you to get, I don't want you to be giving that chemotherapy without the right personal protective equipment. Here it is. Here's what we use for that drug. Nurses really do take a lead. Hospitals have very strict policies and procedures around that, as does Accreditation Canada. If it's a hospital where chemotherapy is given, they make sure that those standards are going to have to be adhered to. So it's a great question.
It certainly is. We are after 2 o'clock, and we will have to close down this most fascinating conversation. But before people do sign off, I will pass you back to our operator. But on behalf of Jennifer and myself, thank you very much for joining in this webinar. And there will be a post-conference questionnaire for you to complete. Thank you so much.